start recording, and now we're going to go to PowerPoints, and we are going to bring up, what happened? Did I let, oh, gosh, I got out of that. Oh my gosh, I'm so excited. Okay, here we go. All right, we're going to talk about, can everybody see that full screen? Why are we not here?
I see the full white screen.
Everything there, blank screen, get off me, blank screen. Yes. Oh, no, stop, stop.
Full screen going away.
Sorry, give me a minute, people at home.
Listen to a lecture and you can do it after
Laptop. Yes. I don't want to. Why is it not coming up now? Laptop. Why aren't these down? Why are the lights down?
Where does it work? Didn't work.
This is so annoying, people. I'm so sorry. Give me a minute.
Mark Richards will be here soon.
I'm so glad, Mark. Okay, laptop.
That was his technological advancement. Did you guys scan in? My 1% never forgotten that. I just barely did. Forgot twice last week. I texted him. I was like, oh. Hey, I like this.
All right, now we're still on the laptop. Why does it say video recording?
Caffeine. Every 2 hours, I'm like posting something random. Like 4 a.m.
Kim was like, when Kim was texting, I'm about to pull an all-nighter. I was like, I'm about to go to sleep.
It's like midnight. I'm all.
Why does it say? Okay, people, hold on at home. We're still working on this.
My best hours are midnight. I stay awake.
I call it at midnight. And then it's like, all right, yeah, what time is it?
Early show. Yeah.
I'll wake up.
My name is.
McKenna, could you go just wipe my badge over there, this simulation entrance, and find Sean Taylor has a computer. Thank you. Okay, people at home, we're still trying to get our little stuff here to work.
I was struggling. It was like 10:30, 11 o'clock. I was like, this is gonna be a long time.
Why is this not working? I thought this was. Huh?
I like that. It's okay. You don't have to sit with me. I'm not offended. They never sit with me, so I'm not offended.
I had this all working and now it's not working. So let's go back to home.
I still love you.
All right.
Dude, I was like, I don't. I was so pissed that I stayed because after we got done lecturing, I turned off my iPad. I was like, no, I'm not doing this.
Okay.
Too long. Next time I'm just gonna.
Time, tears, and joy.
Why is this not being recognized?
You're already doing better than me.
Okay, we're going to go ahead and start the lecture because we have got to keep moving, people. We have got to keep moving. I don't know why. Moments ago, we had the laptop connected, and now it's not. And the kid, and bless her heart, has gone to go try and find Chantel to see if we can have an issue. But for those of you that have your computers, turn on a Canvas and pull up the adult cardiac lecture and go back to the very first slide that says heart failure, because that's where we're going to start. It's a picture of a heart. Why? Because we're talking about heart failure. And we're just going to start until some help comes. We don't know. Just follow along with the little PowerPoint, okay? And I will say next slide when it comes.
She was right where you said.
I'm so sorry. So look at, I can't get this. It was connected a minute ago. It is not connected now.
So Mark showed me if you go Control F8.
F8.
Oh, yours is on duplicate because mine kept going to extend. So duplicate. So then, if you go, you've got laptop, you've got video, you've got, okay, what did we do? The next time, I think with Annie's, when it did this, we just shut it down and we started it back up. Does that make sense?
So you want me to shut it down?
Yeah, so do that. And then do yes, shut down your room. It's so ridiculous. I'm so sorry.
No,
It's just one more thing, yeah.
It just takes up so much time from the lecture.
Okay.
Get it all in.
All right, so
let's
go
shut this
out of
out.
presentation mode here.
Okay.
Is that okay?
Yeah.
Okay. And then go turn your laptop on. Stop it. All right, so now, now it's coming. Oh, I don't know why it does,
It's okay.
why it takes so much.
But it's not
So
gonna
then
go.
you go
Okay, to the full
and then down into your presentation mode, right? Or are you
So there,
going
or
from
you
here?
just go to full screen.
Oh, this is share screen. Did
That's
you?
what I want to do.
Okay, you want to share your screen.
But see, it never connects with the PowerPoint. So I'm sharing this
So-
whole thing.
Oh, okay. So you have your PowerPoint on down here.
I have it under, hit this little arrow here.
Okay.
And there was.
There's your
Well,
PowerPoint.
there's 2 or 3 PowerPoints. But
So which
it is
one do you want?
taken-
This
it's-
one?
No, it's taken out the one that I want. I have to load
Okay.
it back up again. So I go to
Okay.
File,
Okay.
and then you're going to go to, well, go over to Page
Okay.
Drive.
Drive.
Nurse. And then here.
The UTC.
Mhm. And 1050. And then PowerPoint.
And Vicky.
And then Fall. And then right up here with the adult cardiac is the first one.
Right here.
Uh-huh.
Okay.
So as long as, and then just hit slideshow, we'll go from there.
Yeah.
5G, watch out.
And from the current slide. So there you go. You got that to go. Is somebody have Blue Button up that can watch the chat for her? You
Yeah.
guys are amazing.
Okay, aren't they
We don't have enough screens. Okay, you good?
Yeah. I'm good.
Okay.
Thank you so much. You're wonderful. Let's all give Chantal a hand.
It's because Mark just so much.
Thank you, Mark. We would have been here. Okay, let's plow through this, people, because we got to keep going. And this is an important part of the adult cardiac portion of next week's exam. Now, remember, I think I broke down the exam to you. There will be 30 questions on this first lecture, and then 10 on vascular, 10 on hematologic, and then 10 from Chantel on her portion tomorrow. Okay? Okay, let's plow through. All right, so heart failure, and we started this a little bit and then we stopped last week so that you could go to lunch, but heart failure can be the result of many, many things. And the thing about it is that people think, hear the diagnosis heart failure, they think, oh my gosh, I'm going to die next month. And that's not the case. If it is an acute situation, usually it's very severe and is the result of a myocardial infarction. However, it can be a very slow, chronic, progressive disease that takes months or even years to be terminal. So there's just things about this that we need to understand because, as we talked about previously, that when you're in the hospital in an acute care setting, which you all are in clinicals right now, you are going to have a majority of your patients be elderly. And so many of them will be in heart failure. It used to be called congestive heart failure, but it's not called that anymore because there's so many things that contribute that can be causing the heart to fail. But it's not necessarily congestive heart failure, or depending on the continuum of where the person is at in the disease process, it's not going to always come forth or present with pulmonary edema or that type of thing. So we're going to look at this. There is congestion, but it can be pulmonary or it can be systemic. So we're going to talk about the differences in that today. But the thing about heart failure, as I said before, in an acute care situation, an acute heart failure, it's usually the result of a myocardial infarction. But many times people will be in heart failure. It's going to be a chronic condition. It's going to be progressive and it's going to be pretty slow. Now, we talked about last week myocardial infarction. So you need to be able to separate these two because what we're talking about today is going to be more of a chronic issue than it is acute. And it can be the end result. Oh, haven't progressed forward, have I? So, oh, here we go. Now we're down here. Let me get to the heart. Just a minute. Just let's review. Are you getting the review from last week as we go through here? Yeah. One thing, when I said the word review, I will post one Wednesday if you're at all interested. If you're not, it's up to you. You guys know what works for you. Okay, so here we go. So this can be an end result of coronary artery disease. Huge contributing factor. What is a contributing factor for coronary artery disease? Well, that's the causes for the secondary condition, atherosclerosis. Yes, this is where we start forming thrombus and plaque, and you have the narrowing of the arteries. You're going to all review that this week. I know you will. Why? Because it's on the test. So atherosclerosis is the initial precipitating effect. That can be secondary to diabetes. Hypertension is also a huge one. Those are the two main causes of coronary artery disease in the United States. But so atherosclerosis is going to cause a coronary artery disease. And then you have myocardial infarction can result in heart failure, where so much of the a certain part of the heart is damaged or infarcted. Dead tissue, it doesn't work anymore. Cardiomyopathy, that's where you have an enlarged heart. And there's going to be some contributing factors to that we're going to talk about today. Substance abuse. What is a huge drug that is associated with heart failure? Cocaine. Cocaine. You talk like you know what you're talking about over there, Mark. I'm just saying. Yeah, that's Mark Medina. We don't want to get Mark Richards, confused with taking cocaine. All right, vascular disease. Oh, neither Mark was just Mark Medina, Medina. Was just talking about. He was just giving an answer. That was all.
Hey, Vicki.
Yes.
I wonder if we can turn it so that they can see the whole screen.
Okay. Yes, I can. Tell me when.
Keep going. Keep going. Keep going. Keep going.
Gosh.
You might want to back it up a little bit so you can get more.
Okay.
Almost.
That's as far as I can go. What if I back this up more?
I think you got to tip it down a little more. And then left a smidge.
Left to a smidge. Left, your left, my left.
Hey, there it is.
Okay.
I can't read the screen. I mean the title very well. But.
We need a cameraman. That's what I need. I need a staff. I just need this whole entourage of people to go with me wherever I go. How's that? Better? Can I lift it? Next time I will.
Bottom corner, you can't read all the way.
How's that?
Keep going. Almost. Yeah.
Everything? Idle? Everything?
Yeah, I'm just here. That's it.
Okay. All right. So we talked about all that kind of stuff. Read it. I don't care. So, all right. So let's start. Now, see if they can see me on this. No, they can't. We're not doing that. Okay. So let's talk about this for just a minute. Because you have to understand this flow of the blood to understand right and left heart failure. We talked about this last week, so we're going to talk about it again. So the blood, the oxygenated blood, enters the heart from where? Deoxygenated.
Superior vena cava, inferior.
Superior and inferior vena cava comes into the right atria, goes through the tricuspid valve into the right ventricle, goes out of the right ventricle into the pulmonary arteries, goes into the pulmonary vasculature to get oxygenated, comes out of the lungs through the pulmonary veins into the left ventricle, down through the mitral valve, into the left ventricle, and then out the aorta. Now, it is essential that there is enough pressure and contractility. See what they're missing at home? To push the blood through the aortic valve into the peripheral vasculature. Now, hypertension is a huge cause for heart failure because if you have hypertension, you're going to have increased peripheral vascular resistance. So it's going to be harder for that blood to get out the aortic valve into the peripheral vasculature because of this high pressure. So hypertension is a huge issue in heart failure development. It's one of the main issues of heart failure. Now, we learned last week that when Mark Medina goes to the gym and works out, his muscles get big. No. They get bigger. He gets stronger. He looked so good in those scrubs that you all had to wear. So, but with the heart is cardiac muscle. It's not skeletal muscle. So when you push really hard and use that muscle over and over, it gets bigger. But what about the force of the contraction? It decreases. It gets weaker. And because the muscle has gotten bigger, the cavity or the ventricle itself is now smaller and can hold less blood. So now we don't have the force that we need or the contractility to get the blood or enough blood out into the peripheral vasculature. So the output, the blood through the aortic valve that goes out into the peripheral vasculature is called afterload. Okay, so you're going to have preload, you're going to have afterload. How do you know which is which? After means it's gone through the heart. It's oxygenated. Preload is coming into the heart. How much blood is coming into the heart? So we're going to talk about those two different terms. You're going to need to recognize them throughout your nursing career. So become very familiar with them. All right. So what is happening here with left-sided heart failure is that the left ventricle is not able to completely empty of blood or effectively pump blood out through the aorta to the body systems. So, now this is where it gets a little complicated. So you can't push all the blood out of the ventricle, the left ventricle. So what happens to that blood? Because you have blood coming in to the right atria from the whole body here. So, but we can't push all the blood out that's in the ventricle. And remember, the ventricle is much smaller because of this hypertension. So what's going to start happening? You're going to start having backup. And this is this is where, like I said, it gets a little complicated, because where is it going to back up into?
The body. Lungs.
To the lungs, because the lungs is what's feeding the left atria, which is feeding the left ventricle. So now we have this backup of blood in the pulmonary vasculature. Okay, now remember, the vasculature, the pulmonary vasculature breaks down from the pulmonary artery to the arterioles of the pulmonary system into the little tiny capillaries that cover the alveoli. So you think, well, what big deal is it with a little tiny capillaries? Well, that wouldn't be a big deal if there was one or two of them, but there's millions of them. So we have this congestion now, and with the capillaries, what do you have to have gas exchange? I love these masks because I hear mumbling. You got to have pressure. You have to have that oncotic pressure. Do you remember Wendy's lecture? Oh, it's not Wendy's anymore. It's Rachel's lecture from Fundamentals on acid-base balance and fluid balance. No, whatever. Yeah, sure you do. I know you do. But it's oncotic pressure here. Well, now we have a screw up of that because we've got all this congestion. There's a whole bunch more volume in those capillaries and in the pulmonary vasculature. And what's going to happen is that it's all screwed up, and you're going to start having that fluid, the plasma that is normally in the pulmonary vascular, go out into the interstitial tissue, which will eventually come into the alveoli. And so that's what you get with your pulmonary congestion, is that this fluid that is being backed up because of left-sided or left ventricle heart failure is now causing fluid in the pulmonary not only vasculature, but in the alveoli themselves, which is going to result in what? Crackles and poor gas exchange. Now, the thing about the cardiovasculature is that it is a closed system. So once we start having all this buildup of fluid, and we've got this pulmonary congestion, and we have this backup, we're continuing to back up, then where it's a circle, eventually it's going to back up through the system and then cause a decrease or not a decrease, but yes, a decrease in let me get this straight. We're talking about, it's a closed system, left-sided heart failure. We're going to go into, there's going to be a backup, so there's going to be an increase in preload into the right atria, the right ventricle, and then where are we going from there again? Back over to the lungs. And so it's a big circle. So now we're going to have all this extra volume that is in the right ventricle, and it's going to fail. So left heart failure will always result in right failure eventually because of this backup of blood and because this is a closed system. So it doesn't matter if you start out with right heart failure or left heart failure, eventually both sides of the heart will fail because it's a closed system. Okay, does anybody have any questions about this? Think about this again. Backed up blood in the pulmonary vasculature is going to have an effect on the onychotic pressure at the capillary levels, causing excess fluid into the interstitial tissues, which eventually permeates into the alveoli. And then you have fluid in the lungs. So left heart failure, there's going to, the signs and symptoms of that are going to be pulmonary congestion. Okay, let's flip the slide. Woo! And what is going to be the main cause of left-sided heart failure? That's right, but what is causing the hypertrophy of the left ventricle? Hypertension. Know that, people. Know that. All right. So let's look at, and with hypertension or with left-sided heart failure, what is going to happen to the afterload? Increased or decreased? Decreased. Remember, we've got a smaller ventricle now. We have less force to push the blood out. So there's going to be a decreased cardiac output. What happens with decreased cardiac output? Decreased perfusion, exactly, but what else? I hear Victoria mumbling. What?
Fatigue.
You're going to have super fatigue, exactly. You're going to be very fatigued because you have low blood pressure. Why do we have low blood pressure? Because we have low blood volume. Okay. So again, the thing is that you just, but when I say low blood volume, because we have decreased cardiac output, what is the cause again of left-sided heart failure? Hypertension. So you may have high blood pressure because why? Even though you have lower volume, why would you have higher blood pressure? Exactly. You're trying to compensate, but the lumens are smaller. More pressure. Okay. All right. Let's go. Okay, so now we've talked about left-sided. Let's talk about right-sided. Wait a minute. Before we go on, let's go back just a minute. I don't know how to go back. Yes, I will. Well, we'll just go on, and then I'll come back to that. All right, so right-sided heart failure. We talked about this a little bit. So with right-sided heart failure, what happens here is that the right ventricle fails, causing blood to back up into the vena cava. So now our ports of entry, we're not coming from the lungs anymore. We're coming in from the inferior and superior vena cava. All right, so we're entering the right atria and we're going in to the right ventricle. Okay, so what happens here is that if the right side heart begins to fail, blood is going to back up, just like it did in the left ventricle. But this time it's the right ventricle that's failing. So again, we have a smaller ventricle there. We can't push as much blood into the pulmonary vasculature. So what is going to happen here? We're going to back up, and this is called systemic congestion. So that we're going to start backing up. So where are we going to back up into?
The body.
The venous part of the vasculature. The venous part of the vasculature. On the left side, we were trying to pump out into the arterial vasculature. But on the right side, we are being fed by the venous system. So the backup is going to be in the venous system. All right. So now, what do you think the signs and symptoms are going to be with this? Edema. Huge, huge, huge. Good for you. Edema. So again, why? Because now we have a lot of blood backing up into the venous system, the peripheral venous system, and with that backup, it's going to cause the oncotic pressure to go wonky, and so you're going to have this fluid that is being forced into the interstitium because it's too engorged in the vasculature. And that's where we have edema. So what is the first sign that we're, not the first sign, but what is a sign of left-sided heart failure? Pulmonary edema, crackles, fluid in the lungs, difficult to breathe, shortness of breath, all those things that are associated with the pulmonary system. With systemic congestion, we're going to start seeing edema because really this is a whole system that we're dealing with right now. So where do you think we're going to see the edema first?
Lowest body part.
The lowest body parts, because it's the dependent part of the body. You can ease that somewhat by having the person elevate their legs. But when you're standing, sitting all day, the dependent portion of the body is where the edema is going to accumulate. So you see here that with systemic congestion, you're going to see JVDs, which are jugular vein distension. So they're going to be really, really full. You're going to see dependent edema. We talked about that already. As the disease progresses, you're going to start seeing swollen hands and fingers. You're going to have a weight gain. So if you have a weight gain, how much does a kilo weigh in pounds? 2.2 pounds. So yes, so if you so if you have a weight gain, then, and remember, this was, I don't know if it was part of Rachel's, I always knew it was part of Wendy's lecture, was that the weight of a person, a daily weight, will be the best indicator you have of fluid retention. A monthly weight is more accurate, or a weekly weight is more accurate or indicative of what you have gained as far as body mass is concerned. But a daily weight, the same time every day, wearing the same clothes every day, is the best indicator for how much fluid you are retaining. Nocturia, you will sometimes have oliguria during the day, which means you have decreased urine output, but at night you will have increased urinary output. You will have increased blood pressure because of the volume of blood that is in the body. You will have anorexia because this fluid or the blood has now backed up into the GI system. And oh my gosh, the next lecture is going to be GI. It's one of my favorites ever. But you're going to see how the GI system has so much blood vessels that are associated with it that the backup is humongous. So now you have these intestines that are just overloaded, and so you're going to not feel good. You're going to have anorexia. You're going to be nauseated. You might even have some abdominal pain associated with that, and you're going to have engorged abdominal organs such as the liver and the spleen. So it's just when we say systemic, it's systemic. It's everything hurts with right-sided heart failure. But because it's a closed system, what's going to happen eventually? You're going to end up with left-sided heart failure. Okay, this is a little picture that I threw in there because it just basically says in a very shorter period of time what I just said. So look at that. Okay, now look at this. Oh my gosh.
Yeah.
This looks like an all that applies question. Yes.
So is there like a specific disease that's going to start with right-sided heart failure instead of left-sided heart failure that causes it?
Yeah, cor pulmonale.
Okay.
Yes, yes. Okay, so all right, so there's 4 things that you want to be sure and educate your patient about, because when they hear the word heart failure, they're going to fall apart. And like I said, unless this is the result of a myocardial infarction, then this is going to be chronic and this is going to be long-term for them. So they're going to go home from the hospital with this and they have to manage it themselves. And how are they going to manage it themselves? Basically, with these 4 areas, with their medications, you have to tell them to take their medications as prescribed. You cannot miss taking medications. And these little elderly people, a lot of times, are getting their medications from Medicare, and so they get them in the mail. So it does take sometimes. It's not like you're running down to the pharmacy at Walmart to pick up meds. No, you're getting them for 3 months at a time, so you have to order them in advance. So we have to really stress to them they cannot miss their medication. They need to know what the purpose of the medications are, what the side effects are, if they take too many or they take too little. They need to avoid NSAIDs. Now, why would you say to a person in heart failure who potentially could have gotten this, and this is right or left heart failure, so it could potentially be because of a thrombus or an embolus type of here that they've been had some kind of injury to the heart. So why would you tell them to avoid NSAIDs?
Incense. Oh my
God. Incest?
No,
avoid incest at all costs.
Yeah, that's what it is.
Incest. Actually, it's a trick question. We don't know.
Alright.
We really don't know. We just know that when people are on NSAIDs, there has to be, there is some tendency to damage the heart more. It doesn't, they tend to have more problems. We don't really know why. So just be aware of that to avoid NSAIDs.
Does incense have kind of like a stimulus effect?
I don't,
Smelling salts kind of have that, right? Like they'll wake you up and chill it.
yeah, but I don't think NSAIDs do. I don't think so. I don't know. All right, activity. Are they going to be at rest at all times? One of the things we said, when a person has a myocardial infarction, first thing you want them to do is lay down, take the nitro. We want them to rest. We want them to be on bed rest. Yes would be no. We need them to stay as active as possible, knowing what their own limits are. Remember, the complications of immobility are way, 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 way too high to deal with it. So, I mean, it just adds fuel to the fire of a decline in health. So we want them to stay as active as possible, but they need to know what their own limits are. They need to be able to carry on a conversation without getting short of breath. So if they can't talk while they're exercising or walking, that type of thing, they need to slow down, rest, and then they can begin again. We always want to intersperse activity with periods of rest. How many times can we apply that in last week's lecture and today? A lot. Intersperse activities with periods of rest. With diet, we want to limit their sodium intake to 2 to 3 grams of salt daily as prescribed. And daily fluid intake should be 2 to 3 liters of water a day. Not today, but a day.
Just today. Don't worry about it today.
They can have more, but if they're in fluid overload, we have to limit it. Okay. So the goal, and I wanted to stress this, it's a benefit of being in class, is the priority goal of nursing management for a patient in heart failure is to reduce the workload of the heart. Okay, so the signs and symptoms of a person that is in heart failure we want to look at. First of all, let's look at left-sided heart failure. Fatigue. There is not enough energy there to meet the demands of the body. So usually when you're fatigued and tired, you're going to be weak. So there is a weakness there associated with that as well. There could potentially be angina. And if we're not meeting the oxygen demands of the body, then the person could have some diffusion or confusion and restlessness and dizziness. There is something called vascular dementia, where the person is very progressive. People don't, notice it until other people notice it. And that is that you start forgetting, your memory gets very bad, things are a little cloudy. And that's because even though there hasn't been a stroke, maybe we haven't been diagnosed yet with heart failure, but the brain is not getting enough oxygen to meet its metabolic needs. But the person is going to be very tachycardic. They may have palpitations. What's a palpitation feel like? Kind of where you feel that heartbeat. The heart is trying as hard as it can to get that fluid out, and the person will be weak. If you have decreased cardiac output or decreased afterload, you're going to have weak pulses, strong pulses, or bounding pulses. Weak, because you don't have the fluid volume there. And then your extremities are going to be very cool. So when you're trying to remember this, and on the exam, you're going to have questions that give you a scenario with certain signs and symptoms. You're looking, does this talk about increased afterload, decreased afterload, decreased preload, increased preload? But what is happening here? And then, in your mind, I want you to think, what would the signs and symptoms of that be? If there's decreased afterload there, then there's not going to be as much blood volume there, and what's going to happen, with the exception of hypertension, which is cause it. So that's right. That's left-sided heart failure. For right-sided heart failure, you talked about that already. Jugular vein distension. You're going to have dependent edema, weight gain, nocturia, and increased blood pressure because of excess blood volume. So will you have weak or bounding pulses? Right-sided heart failure, weak or bounding pulses? Bounding. Because it's all backed up. Blood's all backed up into the peripheral vasculature. All right, we are going to take a 5-minute break. No, we're going to take a 7-minute break. We're going to come back at 11:15, and we're going to move on to vasculature. Before we go, does anybody have any questions? Is anybody reading questions from my little students out there?
No questions.
Okay. So let's take a 6-minute break and then switch over to the PowerPoint on the vascular system or vascular problems, or something that starts with a V. That VD. I'm not talking about VD today. Although that would be funner, wouldn't it?
Now I'm glad I was never impressed with you one.
Yeah, no, the whole getting done on Monday.
I'm just gonna take dress. Oh, I need to download this. Crap. Friday.
Okay, look at this again. See if I'm in the right place. Who's got their computer on? Is this everything? Are we good with this? Everybody sees it? People at home can see it?
Partially.
Okay, what do they want? Back?
Whoa.
Oh, back this way?
Yes, say And then last.
Stay.
Yes, there.
Good.
Looks good.
Okay.
We'll see once we get the sun up.
Yes, we'll see. We'll see if it works. Oh, I have this. All right, people, we're back. We're moving on, and you're going to find out what is the purpose of arteries.
Carry blood away from the heart.
To carry blood away from oxygenated blood away from the heart. And what is the purpose of veins? Bring deoxygenated blood back to the heart as well. So this is basically what we are discussing today with that. So our objectives are going to be identify components of the vascular assessment, compile a list of lifestyle changes that can decrease a patient's risk of developing a peripheral artery disease, identify the clinical manifestations of each stage of chronic peripheral arterial disease, prioritize nursing interventions for a patient experiencing an acute episode of arterial insufficiency, develop a list of activity modifications a patient with a peripheral arterial disease should use, compile a list of foot care principles a patient with a peripheral arterial disease should follow, compare the clinical manifestations of venous insufficiency to arterial insufficiency, and develop a list of activity modifications a patient with chronic venous insufficiency should follow. And we're going to do that all in 1 hour. Woo, woo! So let's plow through it. All right. So when we're talking about the arteries, then we're talking about bringing oxygenated blood to the tissues of the body to meet their metabolic needs. And we do this through circulation and perfusion. So when we talk about circulation and perfusion, we're being very synonymous here. So don't be confused if you see one or the other question or word utilized in a question. They basically are talking about the same thing. So, and we know this by doing one. What is this? According to Jody. For circulation, the thumb is pulses. The index finger is Capri-fill.
Color.
What is 3?
Temperature.
Temperature. What is 4? Edema. And what is 5? Color. Okay. So we've got that down. I know you still have that memorized and are holding it close to your heart.
Forever.
There you go. So the thing about it is when we are examining the skin and we're doing specifically looking for circulation, if you see somebody that has pallor, what are you looking for? What do you think? Yeah, there's not enough red blood cells there. Okay, there's not enough red blood cells there. We've got to look for that. Remember way back when I told you that a nurse is really a detective. It's not just seeing something. Now we got to find out why that something is something. Okay, so we talk about pallor. What if cyanosis? You see cyanosis. What do you think that's indicative of?
Enough oxygen.
Lack of oxygen. So what else are you going to look for? You just see the skin, you see a little bit of blue here. So what else are you going to look for to see if the person is hypoxic? I can't hear you. You're mumbling.
Breathing.
Breathing. Their work of breathing. Excellent. What else?
I've been awake for a hot minute.
I guess so. You're going to look for perfusion again. Signs and symptoms of perfusion. So now we're going to talk about the venous system and the arterial system. And there's going to be a specific color or discoloration of the skin when there's certain problems with the vasculature. So a reddish brown discoloration that is found in the lower extremities usually will occur with decreased blood flow. A brown discoloration, now remember, reddish brown is going to be arterial. A brown discoloration and cyanosis is usually indicative of somebody that has venous problems or venous blood flow problems in the lower extremities.
What color is that? Reddish brown?
Brown, no, reddish brown is arterial. Just brown is venous. So when you see this discoloration of the skin here, then we want to do some palpation here, also to determine if this is a vascular issue, which it's going to be. It's also signs and symptoms that you want to be able to document. So when you are palpating the lower extremity here, you're going to start approximately just a little bit above where the discoloration begins, and you're going to move down distally. And in areas where there's decreased arterial flow, the ischemic area is going to be cooler than the area above it, or the rest of the body. And this is because blood warms the body. So if you have decreased blood flow to a specific area of the body, it's going to be cooler than the rest of the body. Now, normal capillary refill is what? Less than 3 seconds. And that indicates that there is normal blood flow and return from that portion of the body. But if it's longer than 3 seconds, that means there is a decreased blood flow to that area. All right. So I'm not going to go over this. These are the different pulse points where you can feel in the arterial system the contraction of the heart. So with each pulse that you feel, or pulse beat that you feel, when you're palpating for a pulse, this is indicative of the force of the contraction of the heart. So you can review those signs because you're going to need to know where they are. So how many of you have been on your computers at clinicals and looked for pulse amplitude charts, or you have to document whether it's a +1, +2, +3, +4? Anybody? What if you have a 0? You're pretty much dead. Yeah, right. So we start with a +1. But this is indicative of the strength of the pulse, the strength of the contraction. Now the thing about it is that your facility has its own amplitude scale. So you can have a 5-point scale that begins effectively with 0 and goes up to 4, or you can have one that starts with 1 and goes up to 4, a 4-point scale. So the thing about it is that you need to find out whether +2 is normal for you or +3 is normal for you. +2 or 3 is going to be a normal bounding. It's not really different. Okay, so the same holds true for pitting edema. And I would encourage you to reflect upon these two scales, the amplitude for the pulse and for pitting edema, so that you're able to recognize the different points and what it means. But basically, trace is a minimal depression with pressure. So it's just, oh my gosh, there's just a little bit of edema. Maybe they look at their finger and they can't get their ring off or something. It's pretty minimal. But then you start getting 1 point, +1, +2, +3, +4. And +1 is where you hold your thumb down on that edema. Usually the edema is going to begin in the ankle joint area where it's going to start to accumulate. And you hold your thumb against that area of the body for 5 seconds, depressing with some firmness and a little bit of pressure. And then when you lift, you determine that a +1 would have a 2 millimeter depression, and there's a rapid return. But look at what down here if you have a +4. This means that there's going to be an 8 millimeter depression that persists for 2 or 3 seconds. Do you think this person is going to be in serious heart failure or not?
Yeah.
It's going to be. The worse the heart failure is on the person is going to be the worse edema. Now, what else can cause an accumulation of fluid and cause edema? Fluid overload is going to be one. But liver. Liver failure is also going to cause edema because of the production of ascites fluid that's going to start accumulating. Now, there are specific assessments too that you'll want to do to determine circulation and to make sure that it is a patent vascular system. And that, of course, is going to be your neurovascular check, and it's going to include the circulation that we talked about earlier with the five points of circulation. And I encourage you to review that again too, so that it comes to you really, really fast. But because the CMS involves circulation, that can be a test or a diagnostic test to determine if the person circulation is patent. But there's the Allen's test. Now, the Allen's test is used to find abnormal pulse findings and the arterial flow in the hands. And the reason why they do this is they're determining whether it's the ulnar or the radial pulse that has the best blood flow to it so that they can stick an arterial line. What's an arterial line?
Blood pressure.
It's, instead of putting, it's a continuous blood pressure monitor. It's real time, and it tells you every second what the person's blood pressure is and any vacillation of pressure. Really used for critically ill people, and it has to be done with a pressure bag and an arterial blood catheter. When I say pressure line, that means that they have a continuous flow of normal saline going into that catheter, because we don't want an artery to clot off. So we have this continuous flow of normal saline going into the catheter that is inserted into an artery to monitor continuous blood pressure. So the Berger's test usually is used to assess arterial sufficiency, and the color should return in 10 seconds to this. And this is oftentimes, what does cigarette smoking cause you to do? Vasoconstrict. So when somebody, has been smoking a pack for 20 years. You know, a lot of times they will do a Berger's test on the hands to determine what the return is to the blood flow return is, usually related to cigarette smoking. All right, so let's talk about the venous insufficiency here for just a minute. And here, once again, we're going to talk about the human anatomy for just a minute. So with arterial vasculature, again, we're talking about a closed system. So you have your arteries that go down to your arterioles, that go down to your capillaries. And at the capillary level, you have the blood go out of the system. And then as it goes out, the pressure changes. And then on the venous side of the capillary, it takes the oxygenated blood back into the system. Now, the arterial system flows down throughout the body, does it not? Yes, it does. I'll answer that for you. And the venous system comes back up to the heart, but the thing about the venous system is that it comes across against gravity. So in the venous system, what you're going to have that you don't have in the arterial system is valves. You have one-way valves that as the blood goes up against gravity towards the heart, the valves allow the blood to go back up through the valve, and then it shuts so that the blood can't come back down between contractions. And so theoretically, that blood is pushed up, pushed up, pushed up. It never stagnates or coagulates or accumulates anywhere. Who are we waving at? Annie. Oh, hi, Annie. So anyway, so it goes back up there, but we have these one-way valves to do it. Now, as a person ages, what can happen is that the valves become less competent. So they don't close totally. So what you have here is that instead of going up, 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 these incompetent valves, can you see this? Can you see me? I don't think you can. But you have blood that is either with just a minimally incompetent valve trickle down to the previous segment of the vessel. But if it's really incompetent, then you're going to have it kind of, a whole lot of it's going to go up during the contraction of the heart and then just kind of stagnate there. What happens with stagnant blood? It clots. Now, the problem with people that age that have venous insufficiency is that they may have 1, 2, or 3 valves in a row, just multiple valves. It doesn't have to be especially 3, but it's just multiple valves, sequential valves that don't close totally. And now you have a clot that is developed, and it's a big long clot. And so now you have real problems because now you're going to have backup here, and there's not going to be sufficient blood flow. Now, if it's totally occluded, you suck. What can I tell you? You're in big problems, big problems. But for people that don't have that total occlusion here, you have decreased blood flow to that area of the tissue that is supposed to be perfused and allowing arteries and that type of thing and taking out the venous blood from the area. So you have this backup of blood and pressure in the venous system. Now, when you have pressure on the external dermis of the skin, when a person lays in bed for long periods of time, what do they end up with? Pressure ulcer. Why? Because of the pressure. Why? Because the pressure is compressing that tissue that skin tissue, causing it to become ischemic, causing it to die, and you end up with a pressure ulcer. Well, let's think about the inside of the body now. So with a venous insufficiency, you have a blood clot that's developing. And with the more blood that comes up against it, it gets bigger and bigger. Or if it's not big enough to occlude that vein, it is putting pressure on the tissue that comes up against that vessel. So what happens with pressure? Anywhere in the body, doesn't matter where, doesn't matter why, but it's pressure. It's going to compress the tissue that is immediately adjacent to it. And that tissue, because of the compression of the vessels that feed that tissue, is going to become ischemic and die. And it just works its way out outside of the body, and you end up with having a venous ulcer. So the thing about venous ulcers is that they start from the inside out instead of being a skin decubitus that starts externally. The venous insufficiency causes that area of the leg to develop from an ulcer inside out. Do you think that's going to be difficult to fix? It's horrible. It's horrible to fix. Some people, once they develop it, go the rest of their lives having to do daily wound changes because it just never gets the blood flow it needs to heal from the inside out, which is how all wounds heal. So, seeing that venous insufficiency occurs, it occurs because of valve incompetency, or it occurs because of prolonged venous hypertension that stretches the veins and damages the valves. Any questions? All right. Obesity, I just want to throw this out there, that obesity can cause chronically distended veins, which can also lead to damaged vessels. How many of you are familiar with varicose veins? Again, this is a result of congested veins. Okay, so what are the clinical manifestations? Oh, here are the risk factors for it. Age, we've already talked about that. Family history, genetics plays a part of it. Ligamentous laxity, that means there that you've had a hernia of some sort. And when we talk about hernia, we're talking about this bulging type of thing in the vasculature. Prolonged standing, where you have pressure on the venous. When you're standing there for long periods of time, it's harder for the veins to get the blood back up to the heart. So if you have prolonged standing without any relaxation there, then the pressure is always there against the flow of the venous system because of gravity. Obesity, smoking, sedentary lifestyle. Remember, when you're walking and you have activity, then the muscle movement, the contraction of the muscles is going to work against the veins and help move that blood upward. So if you have a sedentary lifestyle, you don't have any supplemental support of moving that blood upward because the muscles aren't contracting. If you have any kind of lower extremity trauma, prior venous thrombosis, and some people are very prone to developing thrombi, and I have to tell you, go back to the adult cardiac lecture that we just did and look at atherosclerosis there, and there are a slide or two about people that are at high risk for developing thrombi, high estrogen states, and hereditary conditions, which seems to me the very same thing as family history. I don't know. I'm just saying. Oh, where the heck did this come from? What?
There's a little X up there.
Yeah, top right.
It's not even on my screen on my computer. It's like just right there. You try doing that backwards. That was wonderful.
Ooh.
Okay. So here is an example of the brown discoloration that you saw. Your clinical manifestations, of course, are going to be ankle or leg swelling. Why? Because of that oncotic pressure, remember? It's got to go, that fluid's got to go somewhere. Varicose veins, stasis, dermatitis, this is that reddish brown that you're going to see. Stasis ulcers. The pulses, are they going to be present or not? Right there it says they're going to be present. Why? We're dealing with the venous system, not the arterial system. So you will have pulses here. Yeah. Arteries, veins. The pulses are going to be present because you're dealing with the venous system, not the arterial system.
I thought arteries was where you have a pulse, not a vein.
What? Say it again. Are we saying the same thing?
We're going to have a pulse because we're dealing with the venous system, not the arterial system. The arterial is where you have a pulse.
That's why with venous stasis, pressure ulcers, or venous stasis or venous insufficiency, you will still have a pulse.
Oh, I thought you meant just with a vein. I was so confused.
Okay. Take a drink, Kim.
Closed captioning.
It cures everything.
What you got in there, Dickie?
Okay, so here's some more fabulous pictures of chronic venous insufficiency. You'll see here that there is a swelling, and this swelling is in the interstitial tissue again. And you compare it to the other leg. You'll also see this discoloration, and right down here, you'll see that the person has started to develop an ulcer. And I can't even tell you, first of all, they're so painful, and second of all, they're so difficult to fix. So the focus, I'm just saying, if I were to take a test, and in my lecture I heard the professor, I'm not really a professor, I'm just the instructor. So anyway, so I heard the professor, not an instructor, but the professor say the focus of, the goal of, I would highlight that. I don't know why. That's just me. I just threw that in. Anyway, the focus of treating venous insufficiency is to decrease edema and promote venous return from the affected legs. Patients are not hospitalized for venous insufficiency alone unless it is complicated by an ulcer. And the goal of someone that has a venous stasis ulcer is to heal the ulcer, prevent infection, and prevent the reoccurrence of stasis. Now, how are we going to do that? There's interventions that we can do to prevent this from happening. So one of the first things that you're going to find is that compression wraps are necessary to decrease the edema. Now, to be effective, do you think the compression stocking needs to go to the knee, or does it need to be thigh high? Thigh high, exactly. So, what assessment do you think now the problem with compression stockings or with a wrap, if they, the cheapo depot thing that they'll do, if you don't have compression stockings, is to do a wrap, an ACE wrap. But how do you know, what assessment can the nurse do to determine that the wrap, the ACE wrap, is not too tight? Exactly. You can do a CMS or the perfusion circulation. But you want to be able to make sure they can wiggle their toes, that they can sense your touch. You don't want to make it too tight. So that's the problem with ACE wraps. Now, you want to have them remember that edema is going to happen when they're standing. And so we want them to elevate their legs at least 20 minutes, 4 or 5 times a day. We were talking about compression stockings there for a minute. I did want to say, too, that when you're helping or assisting the patient to get undressed for bed, and you take off their socks and you see indentation from the socks, and you know the socks were too tight. So you need to be looking all the time, looking for this pitting edema that will eventually, if the pressure from the edema is not relieved, then sustained pressure is going to begin the beginnings of that ulcer. So what we're looking for, are the socks too tight? Yes. Then we want to get on some compression stockings to minimize the edema. Avoid long periods of standing. Now, the foot of the bed should be elevated 4 to 6 inches. And the thing about it is that when you elevate the bed like this, do we want them to elevate? Well, I don't know how to say this. I'll just tell you the answer. We want them to be elevated pretty much like a Trendelenburg position, because if you just have them bend their legs to elevate their legs, then you're going to decrease the lumen size of the vein at whatever point that they're bending. Do you understand what I'm saying here? So you want them to have just the foot of the bed elevated. You're still in a flat position, but the foot of the bed is elevated. Compression wraps and elevating the lower extremities is key to therapy. Okay, and patients that are at home having home therapy may need a home health nurse to come by, change dressings, and help them apply their compression stockings, because getting those suckers on is very difficult. All right, we've got just 25 more minutes, so let's talk about peripheral arterial disease. Why is that doing that? How do I undo that now? This is driving me just to the point of no return. I don't mind telling you.
Oh, you had closed captions there for a minute.
That was pretty cool.
I did?
Yeah. Oh, yeah, it's going across the bottom.
I did? Fabulous.
For like 10 minutes. It was pretty cool.
Cool.
Very distracting. Very distracting.
How do I get this undone? Can I ask? Art?
Ooh, wait.
I don't know what caused this to happen. There we go. No, I got it.
Yeah, it's called a beauty.
Okay, peripheral artery disease. All right, so this is a result of systemic atherosclerosis. Now, if you have atherosclerosis, what's happening? You have plaque buildup, which is narrowing the lumens of the arterial system. So what happens when that occurs in the brain? Have a stroke. Exactly. What happens when you have that in the heart? Have a heart attack. What happens when you have that in the lungs? You have a pulmonary embolism. So the thing about it is atherosclerosis can develop anywhere in the body. So when it happens in the legs, then you're going to have a partial or total occlusion of the arteries. And it can happen in the lower legs. And the thing about it is that the same factors, risk factors that are associated with coronary artery disease or venous insufficiency as well are going to be the same risk factors for peripheral artery disease. So hyperlipidemia, diabetes, cigarette smoking, obesity, family disposition, any of those factors are contributing factors to the development of atherosclerosis and puts the person at risk for peripheral arterial disease. African Americans are more affected than other groups and are generally occur in men that are greater than 45 years of age. Also, postmenopausal women.
Of course, go ahead.
So what are the clinical manifestations of peripheral arterial disease? So the problem with that is the same thing that is a problem with coronary artery disease or any other kind of disease that is preceded by atherosclerosis. And that is that the first stage is where it's asymptomatic. You have no idea that you're developing it. Same holds true when you have hypertension that will result in heart failure. You have no idea it's happening. You don't feel anything. You don't have any symptoms. But stage 2 is claudication. What is claudication? Have you heard of that? Claudication is where you have pain with exercise. So when you're out walking and all of a sudden your calf gets a cramp in it. Is that you? You're screwed, that's right. Then what is happening here is that the supply of oxygen to the muscles is decreased. So what do we do when we are having angina?
Lay down.
No, we don't take nitroglycerin. The first thing is stop and rest. And that's what we want to do with claudication. We want to decrease the demand of the muscles for oxygen. So we stop and rest. That's claudication. And so when you have pain with exercise or activity and you stop and rest, then that is going to be called claudication. Now, as the PAD, peripheral artery disease, increases, then your leg is going to start hurting when you're at rest. What happens with the heart when your angina progresses? You're going to have unstable angina. Were you raising your hand?
Yeah, a little bit. Do we need to fast forward on the slide a little bit?
Maybe. 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 Let me go down here and see if I can find something that will move it. Here we go. Did we need to? Not yet, but that's okay. We're just talking away. Okay, so rest pain is going to show that there is a progression in the peripheral artery disease.
So is that like a third stage then?
Yes. Stage 3. So remember with venous insufficiency, what did we do as an intervention for that? Elevate the leg. So with peripheral artery disease, which way is the blood flowing? So what are we going to do to relieve the pain and increase blood flow with peripheral artery disease? We're going to lower the legs. We're going to have them hang over the bed. We're going to dangle the legs because we want to increase the blood flow there. So, additional clinical manifestations or signs and symptoms of a person with PAD is that there's going to be color changes. So, you're going to notice that the leg is going to be pale when the legs are elevated. When the leg is in a dependent position or it's dangling off the side of the bed, it's going to be this reddish purple color. And even when the person is in a warm environment, because of decreased blood flow, what do you think the temperature of the extremity is going to be? Cool. Not cold, but cool. They still have some blood flow there. Cool. It's cool. Also, with peripheral artery disease, there's going to be some hair loss on the lower half and the ankle and the foot. So mark your hairy feet.
Yeah, I was like, that's awesome.
I know you won't have to shave ever again. You think the foot is going to be, the lower half of the leg is going to be dry or flaky? Yes, it will be. And here's something nice and disgusting. The toenails are thick and yellow.
Beautiful.
So as the occlusion progresses, what do you think is going to happen to the pulses? Decrease. They're going to become diminished, or they may become absent, and then you're in real trouble. So if you, hi Renee. Renee's in the room.
She's online.
Okay.
Okay, thank you.
Okay. All right. So if you are doing your CMS check there and you notice that there are significantly diminished pulses, or there are no pulses, you need to notify the RN immediately. Now, we talked about stage 1, 2, and 3. Stage 1 is where a person is asymptomatic. 2 is claudication. 3 is rest pain. What do you think stage 4 is going to be? Recognize that the signs and symptoms have gotten progressively worse. So now there is pain. The muscles, when they are at rest, aren't even getting the oxygen they need. So what do you think stage 4 is going to be? Total occlusion, exactly. And you're going to end up with necrosis and gangrene. So So the biggest complication that you're going to have with peripheral arterial disease is necrosis or gangrene. Well, you got to take care of it. Okay, now we can look at this fabulous picture. So, lifestyle modifications, what are we going to instruct our patients on, give them patient education? Stop using nicotine. Yes, ma'am.
I had a question online. Stephanie was wondering if we need to know the 4 stages for the exam.
Yes, ma'am. That would be a yes. That was claudication, which is pain when exercising or with activity. And then the one up from that would be pain at rest. And this progresses pretty much like stable angina to unstable angina. Then myocardial infarction. What happens with myocardial infarction? There's a total occlusion there and the heart muscle is dying. Same thing's happening here. We progress until the point where it's gangrene because there's no perfusion there. Just think it through, it all blends together. Okay, so we want a low-fat diet. We want to control our hypertension, maintain a healthy weight, exercise, decrease stress, and control blood glucose levels. Why do we have to control blood glucose levels? Well, blood glucose, the glucose molecules are just really, really big, and they don't go through the vessel walls. And so what happens here is instead of like fluid, like your plasma, like your red blood cells, those type of things, those can permeate the vessel walls in a capillary and then go do their magic, and then they come back into the venous system through the vessel walls. Well, glucose molecules are too big. So what happens there? They adhere to the walls of the vasculature, which potentiates or exacerbates the beginning or atherosclerosis that's already there. Okay. Now, the one thing that you're happening here, so you're developing PAD here, and so you start, you're exercising, you're doing everything you can, but you know what? You sit there and you're just prone. It's a hereditary thing to developing atherosclerosis. You have atherosclerosis. Now you're starting to get claudication, you notice, so you stop and rest, and you think it's just, you haven't eaten your banana today or whatever has potassium in it, so you just think that that's the cause of this cramping type of thing. Then it progresses even more, and you have pain at rest. And so the thing about it is, and you learned this in your human anatomy and physiology, I'm sure, is that when you, and this is true, and I think I mentioned this in the last lecture, that people that have heart attacks at 40 are more likely to die than people at 70. And the reason why at 70 they have a better chance of surviving is because there has been the development of what in the coronary circulation. And I know you learned about this in human anatomy and physiology. Anybody? We're talking about collateral circulation. People that have angina, controlled angina, if they're starting to get occluded, then there is collateral circulation that will develop. A person in their 70s has had time to develop that, to feed that area of the heart that that has been occluded by atherosclerosis. Those new vessels haven't developed that narrowing of the artery yet. Well, the same holds true with peripheral artery disease. If you have pain that has moved on to where you even have pain at rest, does that mean we're not going to walk anymore or have any activity down there? We have got to develop this collateral circulation. So if you start developing cramping with activity, you want to encourage your patients to continue their activity, continue to walk. If they aren't walking, start walking and start walking for long periods so that this collateral circulation can develop in the musculature of the legs, so that when you have a totally occluded peripheral artery, then you have this collateral arterial vessels that can still feed the muscles of the legs. Does that make sense?
You can just take your mask off.
I do?
You can, just take it off.
Are you sure?
Yeah.
Yeah, we don't believe in the virus.
No, we've got shields here, up there.
Okay. I just feel so much better. Why? Because I can drink. Okay, so the guidelines are going to be for a person with peripheral arterial disease is to begin a walking program. Even though it hurts people, we got to do it. Start on a flat surface and walk up to 30 minutes a day. Walk every day, even Sundays. And you'll want to increase the increments in small pieces, just like it is for cardiac rehabilitation. Again, we don't want to stop activity. The human body was built to move. And when you're not moving, then you're going to develop problems. And so we don't just stop moving. So the same thing that happened with cardiac rehabilitation, you increase, you progress in increments. The same holds true with peripheral arterial disease. And you want, even after you have the pain, you want to walk at least a half a block or a block according to your PCP's orders or prescription, how much more you should walk even through the pain. And so over time, you're going to develop some collateral circulation. All right. Now, here's some interventions that we want to do for peripheral artery disease. Okay. Because swelling prevents arterial blood flow, then the feet should be elevated, but they shouldn't be above the level of the heart. Okay. So when we're talking about what do you do to increase blood flow, you're going to dangle. That's fine. But if it's too painful to stand, then you want to elevate them a little bit. You can put them in a recliner. But you don't want to put those legs above the level of the heart. Why? You're going to go against gravity. Exactly. The heart has to work harder to make that blood move. So with the venous system, how high do you want to elevate the legs? Above the heart. Peripheral below the heart. And just think of what direction is the blood flowing in that particular system. And that will help you know what we're trying to do with feet elevation. We talked about that. Okay, so teach the patient not to elevate the legs above the level of the heart. If swelling occurs in the legs, then elevate the legs enough to prevent swelling. And I have to tell you that one of the things that are often encouraged is having the person sleep in a recliner. And we've already talked about them dangling off the side of the bed. I'm just looking for people at home. We just have a few more minutes here, so. Okay, so what if the patient has both peripheral artery disease and venous insufficiency? How high are we going to elevate those legs? They suck, I know. They really, truly suck. So how high are we going to elevate those legs?
6 inches. No way, I got one.
Yes, you did. The thing is, we don't want to go above the level of the heart ever if they have both. Do you think you're going to have a positioning question on the test? I'm just asking. Just asking. Okay. So I think we got everything up to date. All right. So guidelines for promoting a vasodilation. Maintain a warm temperature and avoid chilling. Discourage tobacco use. Has there been any disease process last semester or this semester where it doesn't matter if you smoke or not? Yeah. Smoking cessation. Yeah. It's always an option. Avoid emotional upsets, avoid constrictive clothing, avoid crossing the legs. Administer vasodilation medication as prescribed. Know that sensitivity is decreased in the affected limb so that they may have neuropathy. What do you think is going to happen to one of these lower extremities if they stub their toe or they develop a stage 1 or stage 2 pressure ulcer because of ill-fitting feet, ill-fitting shoes? Yeah, it's going to exacerbate any circulation problem that you have. It's going to be very difficult to heal. Drink plenty of fluids to prevent increased blood viscosity. And wear socks and insulated shoes at all times. Okay. Emotional stress, caffeine, and nicotine also cause vasoconstriction. So complete abstinence from smoking or chewing tobacco is the most effective method of preventing vasoconstriction. We want to avoid vasoconstriction at all costs. Thus, the insulated shoes. Want them to have warm feet when they go out in the snow. Right. So one of the things that you have a problem with peripheral artery disease is foot care because of the distal extremities. Because this is the part that the feet are like the lower extremities. They are the most distal from the heart. They're getting the least circulation of any part of the body. So we have to take care of the feet. And these people, because of decreased sensation in the feet, and they may injure their foot, like I said, and not be able to know it. And so they don't address it. They don't take care of it. And so a lot of time, who was it? Oh, it was a PN1. I had a PN1 in clinicals last week. And was doing the baseline assessment. The nurse, her preceptor, had already done the baseline assessment, was just kind of waiting on the student to finish her assessment. The student took off the foot.
Oh, whoa.
She just took it off. She took off the sock, which the nurse had not done, and found a stage 3 pressure ulcer on the toe that had never been documented, and the patient had been admitted 3 days prior to that.
They're not
They're not getting paid. So the thing about it is that the feet, often because the person has slippers on, often because they have socks on, or you were in pass-offs and you didn't want to bother to take off your classmate's shoes and socks, you just don't check. Well, that can have devastating effects for somebody that has either venous insufficiency or peripheral artery disease. So you have to go all the way down and assess every part of the body when the people are suffering from these disease processes. So you always want to keep the feet clean, keep them dry. You need to have them avoid injury to the foot if at all possible. Never go barefooted. Keep the toenails clean and filed. Because, if those toenails get too long, they can start digging into an adjacent toe. Prevent exposure to extreme heat. Never use a heating pad on the feet. Avoid constricting garments. Use lubricating lotions and see a podiatrist. That's why some nurses earn their living is by going. They do work for a podiatrist, and they go from nursing home to nursing home and check the patient's feet and assess them, especially because of diabetes as well as these other disease processes. And there's good money in it, people. There is dang good money in it. So just keep it in mind as a potential work occupation you may want to have.
No, thanks. Hard pass.
Okay, so with foot care, I don't know if this is on the next slide or not, is it? Nope, it's not. Let's go back. I don't know how to go back. Well, with foot care, just real briefly, you want to daily, if you're at home, you teach a family member to inspect the patient's feet, wash them, dry and gentle patting, don't rub them, lubricant to prevent cracking, wear clean socks, do not walk barefoot, we already said that, and inspect for damage. Okay, so this is what happens, the complication that happens with acute arterial disease. What did we say? The end stage is going to be a peripheral arterial disease, necrosis or gangrene. So this is what happens with total occlusion. And a total occlusion of any artery doesn't have to be in the legs, but it can be anywhere, is going to be a medical emergency, because anything distal to that, if it doesn't get oxygen, is going to become ischemic and then necrose and then die. You're going to die. So it's just, I don't say you're going to die. That part of the tissue is going to die. And you're going to end up with big old problems here. And so this is an example of an arterial occlusion. And you see here the line of demarcation. So where do you think the occluded artery is? Probably right here. Wherever the discoloration starts, that's where the occlusion is. Because everything above that is getting fed. So you notice that you have that deep purplish red color that we talked about earlier when there's total occlusion. And again, how long do you have before this leg is going to become necrotic? Not very long. That's right. So the thing about it is, and this is the thing about dead tissue, is dead tissue kind of lives, or the necrosis puts out toxins, and the toxins live off of live tissue. So you'll see this area start working its way up the leg. So if you leave it this way for very long, then you're going to see the discoloration start moving up the leg, because the toxins from the necrosis and the gangrene are going to live off the live tissue. This is why you see people that are diabetic and they lose their toes, will then lose their feet, and then will lose their below the knee, and then they'll lose above the knee, and it can even go up into the torso. Yeah, not fun. I'm just saying. So what kind of check do we want to do with this? This guy. CMS, thank you very much. And again, this is an emergent situation, so we have to alert the physician, and the patient will be transferred to ICU immediately. They'll be put on a thrombolytic therapy, so our anticoagulant, which is going to be your heparin, that will prevent any future clots from developing. But what are they going to use as a thrombolytic? TPA, streptokinase, ATP, one of the three. They may have to go in and remove the clot surgically or amputate anything below. And what? Boom! I'm done. We're done, people. Any questions? I'm excited. I'm excited. Why? Because we got through that lecture today with 6 seconds to spare. I know. Okay. Just go home. You can get out early. We're fine. I'll see you tomorrow. I'll see you tomorrow. Now, acute cardiac disorders, vascular, and hematologic, which we're going to discuss tomorrow, is what's on the test next Monday.
The quiz is just vascular, right?
Yeah,
Quiz
so we
tomorrow.
got-
There's no adult cardiac on the quiz tomorrow, right?
That's right. Just vasculature.
Oh shit, I don't know anything. You send me a copy of that? Yeah. Well, I'm fine.
We're gonna do the blackout.